I'm going to go back real quick to right here. Just because my pin's working now, and I wrote a minus instead of a plus. So in order to calculate MAP, you can do it two ways. Oops, that's not how I want to do it. MAP can be calculated either by systolic blood pressure plus 2 times diastolic blood pressure, all divided by 3, okay? Or by diastolic blood pressure plus, and I think I said minus, so I apologize, plus 1/3 systolic minus diastolic. Okay? Just so you guys have it in the recording when you're watching, or if you watch again. And to clarify the plus. All right. So let's go back to head injury. All right. So a head injury is any trauma to, I cheated a little bit, to the skull, the scalp, or the brain. A traumatic brain injury is a serious form of head injury. And there is a high incidence of head injuries. So, what do we think is one of the main causes? Car accidents, MVCs, falls, yeah, firearm, assaults, sports, yep, recreational, y'all having too much fun and doing stupid things. And this one I find funny, but it's true, war. I mean, people don't, it's not funny. I should take that back. I don't think it's funny, war. But I think it's like, it's something we don't think about, but it's very true. Okay? Yes. All right. So, with head injuries, there's a high potential for poor outcome. Deaths can occur in any 3 points after the injury. So it can occur immediately. So either from the direct head trauma itself or from a massive hemorrhage and shock at the time of the injury. It can occur, oh, there it is. It can occur within 2 hours. So basically, you had the initial head injury, your patient was doing fine, and all of a sudden the bleed worsens. Or you have some other injury, you have some internal bleeding. Or it can happen 3 weeks later, when basically the whole system fails, because we're not getting perfusion. And we're going to talk about all the different types. It can be diffuse, so the whole brain injury, or it can just be in one spot, focal. And it can be minor, moderate, or severe. So what was one of the, I would just focus more, all y'all, on that it could be right away, a couple hours later, or it could be weeks later. Okay, So we said there was 3 types of head injuries. What was the first one? Scalp. Okay. So what is a scalp injury? All right, just right here. External head trauma. Outside. And what are complications, do you think, of a scalp? Infection. And someone else said it. Blood loss. Good job. You catch your head. Those suckers bleed. Has anyone seen like... Yeah. I mean, scalp lacerations, they are bloody little suckers. Even like a tiny little cut. Those suckers can bleed. The blood vessels are all so close. But also there's a risk for infection if they don't get cleaned out right. All right, that was super in-depth. Ready to move on? All right, so we have scalp. Then we have skull fractures. So they can be linear or depressed. So linear is just like basically a line, right? Linear. They can be depressed where, like, let's say this is this skull and there's like a little dent, right? Depressed. They can be simple, where you just have the depression or the linear fracture, or they can be comminuted, where they have fragments, right? Where little pieces of bone break off. Or they can be compound and have multiple components to it. And they can be closed or open. So you can have a fracture of the skull where someone gets hit on the head with a baseball bat and it causes a linear, though they would call it, and this is how they would describe it, a simple, linear, closed fracture. Meaning there's no opening to the brain matter. It's just one little line and it's simple. There's no other involvement. Or they're involved in a rollover MVC and they have a depressed, comminuted, open skull fracture. So that's how they would describe it. So what do you think are some complications? We just said in the others. Infection. They can get bleeding, a hematoma. Or they can have some tissue damage. Oftentimes, the location of the skull fracture is going to determine your clinical manifestations. Does that make sense? Location equals what type of clinical manifestations you're going to have. So in general, all skull fractures are at risk for infection. All skull fractures are at risk for hemorrhage or tissue damage. But let's say you have like a fracture at the base of the skull. This is where you see symptoms like the raccoon eyes or the battle sign. So a basilar skull fracture, you typically get the raccoon eyes. Oh, I keep wanting to go to the thing. I should go here. So see the little eyes are all purple around. Now he looks like he's wearing glasses. He does. He looks like a superhero. Or they get the battle sign. And the battle sign is that bruising behind the ear. So different skull fractures will have different clinical manifestations. But one of the ones that we talk about and we hear about a lot because it's important is a basilar skull fracture. They get the raccoon eyes and the battle sign. The C is just like a true life example of the battle sign right there, that bruising.
Do they get that immediately, or is it just like a gradual?
It's not right away, but it doesn't take like
an hour?
Yeah, I would say within. It's not like it's going to show up a week later. It's going to show up within an hour or so of getting the injury. All right. And then one of our diagnostics that we use, oh, the raccoon eyes battle sign, sorry. We need to be careful of any rhinorrhea or otorrhea because it could be what that's leaking out? CSF. So how do we test to see if it's CSF? They may just have had a cold when they got into an accident.
So I heard you put something on the
Put it on a gauze.
glucose strip.
Yeah.
Glucose strip.
Okay, so basically you're looking for the halo sign. You need it to be on a white piece of paper or white gauze. You're going to put that drop, and just like it shows, it's, well, it kind of shows. This looks blue, but it's going to be yellow around with red center. That's the halo sign. That tells you it's CSF. What's your question?
We were saying because there's two different tests, but when blood is involved, you typically want to use that test.
Mm.
If there's no blood, then use that.
Yeah, because blood has what in it?
Glucose.
Yeah, that's why we don't always use a glucose strip, because if you use a glucose strip and there's blood, it's going to come back positive regardless. So if you want to determine if it's CSF, you use the halo sign. That's a good question. See, you should share those things with the class.
Well, I was explaining.
All right. So, and like I said, in order to see that yellow with red, it has to be on a white piece of gauze. So how are we going to treat it? If it's a linear, non-depressed, simple, closed skull fracture, we just might watch them. There's not much we can do, right? Are we going to put the skull in a cast? Right? I mean, that would be kind of silly. They'd be wearing a helmet, I guess. I don't know. But we would just kind of conservatively watch them. If it's really severe, let's say it's depressed. Let's say it's comminuted. Let's say it has fragments. They may need a craniotomy. They may need to go in and get surgery done to repair that depression. They may need to, I hate to say it like this, but like a car dent where you pop it back out. They may need to kind of bring that back up. Or if there's a bunch of pieces, they may need to do some remodeling or put something there, okay? So skull fracture treatment really varies depending on how severe it is. So we said that they can be diffuse or localized, right? So if it's a diffuse head injury, that's what we're talking about when we talk about concussions. So what is it? It is a brief disruption in the level of consciousness. Like I said, it's diffuse. Seems kind of repetitive. I don't know why I did it twice. One of the hallmark clinical manifestations is a retrograde amnesia. Does anyone know what that is?
You remember things from the past?
Yeah, they just don't remember the event itself. They can remember up to the event, but they can't remember the event itself. They can complain of headache. Normally, any clinical manifestations don't last a long time. They short duration. However, it can result in this post-concussion syndrome. They can get a persistent headache, behavior changes, lethargy, decreased attention, decreased short-term memory, and changes in intellect. So most people think of a concussion, you hit your head really hard, right? And this is what a lot of sports people are talking about, where they get knocked really hard and they get a concussion. And for the most part, and they have a brief loss of consciousness. They get like a football player. They get sacked really hard. They're out cold on the field for, 20 seconds. And then they wake up. They say, oh, what the freak just happened to me? And then they say, oh, man, you got hit really hard. They maybe have a little headache that day, that night. But tomorrow, they're okay. All right? For some, it can happen after one time, and why they're studying it so much is that obviously the more times you get hit and have a concussion, the more likely you are to have this post-concussive syndrome. But like I said, it can happen even after just one time. And we don't understand really why some people develop it and some people don't. It can have lifelong effects. That's why, wasn't there that movie with Will Smith? I think it was called Concussion, right? Yeah. I always forget that. So, as I say it. So they can have these persistent symptoms where they have headache and behavior changes and changes in intellect. We have one of our ER doctors now is like doing sports medicine, and he studies this big time, like post-concussion. And he actually has patients come in, and they actually do like a intellect test, and then they come back every like so often and take that same test and see if they're getting better or worse. They look at a concussion like basically your brain is bruised and it needs to rest. So when treatment, if they have no LOC or LOC less than 5 minutes, we just observe them. If it's, I'm going back. If it's anything more than that, we typically when we talk about concussions, it's going to be less than 5 minutes. But if they're having any of these signs and symptoms of a post-concussion syndrome, then we're going to start seeing other physicians and interdisciplinary people. A lot of times they just want them to rest. Like I said, it's like a bruise to the brain. So just like we would if we bruised our arm or hurt it, we wouldn't use it as much. They want decreased stimulation. So that's really hard because if you think about it, it's happening to a lot of like teenagers who are out there playing these sports because sports have gotten way intense. At least it feels like. So but it's hard because they have their TVs and their cell phones and they have these high demands in school. So we need them to rest their brain in order for them to improve.
Do they always lose level of consciousness?
Most of the time, yes, but not always. I don't always say always, but most of the time, yes. All right, so that was a diffuse injury, right? Or it could be focal, like a contusion. So concussion, diffuse, contusion, focal. So what is it? It is a bruising of the brain tissue in a specific spot, and it's typically associated with a closed head injury. Like I said, it's focal. A lot of times we think of a contusion when we think of the coup contra coup, where basically like they're going at a fast force and they hit something, and because they hit it at such a fast force, they go back and hit their head back. So you'll think of a kid who's running. I know this is going to sound funny, but this is what we see a lot. Running. They run into a pole and hit the front of their head, and they fall back and hit the back of their head. Okay? A car accident victim. They get flung forward and hit their front of the head on the steering wheel, and then hit their head hard enough on the back of the seat.
Sorry, what was CHI?
Closed head injury. Huh? Yeah. Oh, that's true. You're right. It could just be the shaking, too. It could just be, like Scott said, it could just be from so much force forward that as you go back, even if you don't hit anything, because of the force that's pushing you back, your brain just hitting the back of the skull itself. So, yeah, shaken baby syndrome. They get that, it's the coup contra coup. So it's a primary impact and secondary. So clinical manifestations, they typically have a little hemorrhage that can re-bleed if you don't rest. They can get infarction in that area, so that area can kind of die off, or necrosis. They can get swelling, just like any kind of injury. This is a very specific bruise where, like I said, concussion was like a diffuse kind of, but this is specific. They can get edema around the area. They can have seizures that increase risk of hemorrhage if they're on anticoags. So this is really important to know for your patients, like your older patients, because if you have a patient that came in that say I had a head injury and I felt like, and they're describing this contra coupe injury, and they don't really have symptoms right now, but they're on some anticoags, I would be at high risk. You know, that would make me want to say, I don't want you to go home. I think I want to observe you.
What does a CHI mean? Chronic?
Closed head injury.
So you wouldn't necessarily stop their coagulate.
You may want to
Only
once
if-
they get there. It just
If
depends on the
see
patient.
bleeding, then you
Mhm.
would maybe.
So treatment's typically conservative. We treat symptoms. Again, there's not much we can do. We're going to talk about bleeds in a little bit if they get significant, but it's a specific bruising. A contusion is a specific bruising, and we just kind of treat them conservatively, treat the symptoms. So, we would treat more aggressively if we had any complications. If we have a concussion or a contusion or a skull fracture that resulted in any of these hematomas, then that's when we're going to treat more aggressively. And it's going to be, we have to know the difference between them. So an epidural hematoma is bleeding. Well, first of all, let's go. Do you see the blue? And I'm going to kind of highlight it. That's the dura. It's normally attached to the skull. So I'm going to take it away one more second. I wonder if I play it. Oh, look at that. Can you see it get traced? You want me to play it again slower? So that's the dura. It's attached to the skull. So with an epidural, it's bleeding between the dura and the skull. So this right here. This all right here. So you have the skull. The skull. You have the dura, and there's bleeding in between there. This is an emergency. There is a difference in all the hematomas. There's a difference between a venous bleed and an arterial bleed. Venous bleeds are slow, typically in nature. Arterial bleeds are fast. So if your patient has an epidural hematoma, these are the patients that we do the CT scan. We see that there's an epidural hematoma. Neurosurgery's already been called. They're on their way. They're taking this patient to the OR now to get a burr hole placed in or to get something to drain that bleed.
And that's because of the pressure that it's causing?
Mm-hmm. So typically they have an initial loss of consciousness. Then they'll have this brief lucid period. And then they'll slowly have a decline. So back to our football player. He was hit really hard. He got knocked out on the field. He's out for 20 seconds or so. He wakes up and goes, oh man, what happened? And they're like, oh, you got hit hard. And he's like, oh, okay. And he goes and sits back on the bench. And he's sitting there. And he's getting sleepy. And he's getting tired. And all of a sudden he passes out again. That'd be like an oh sugar moment, right? Butt cheeks just got a little tighter. All right, clinical manifestation, headache, nausea, vomiting. And treatment, we're going to rapidly get that blood out. Either a craniotomy or a burr hole. Blech. So that's different than a subdural hematoma. This is a bleeding between the dura and the meninges. All right, so you've got your dura here now. You've got the meninges, and your bleed is happening right here.
Can you do that one more time?
You've got the dura, and you've got the meninges. This is where your bleed is happening, in here. Okay? Unlike epidural, where it's on top of the dura, subdura, got it? Below. These are usually venous bleeds. So venous bleeds are what? Slow. And they can be in different phases. There's 3 phases. The first being acute, or types, I should say. I'm sorry, 3 types. The first being acute. And this occurs 24 to 48 hours after the injury. Because it's a slow bleed, right? So this is your patient with that counter coup injury that you're like, you were on anti-coags, or it was a really like hard fall. We're going to observe you for the next 24 hours. And then while you're observing them, they start having some increased ICP, some decreased level of consciousness. They might have the headache. They might have the ipsilateral pupil dilation. So they start getting some signs and symptoms of that high ICP.
What does that say? Headache, HA.
Headache or ipsilateral pupil dilation. It's all the clinical manifestations of the high ICP.
Oh, okay.
So you emit them, you watch it, and you're like, oh. And then they rescan them, and they're like, oh, they've got a subdural. Because it was venous, it was kind of slow. There was damage, the blood they started to bleed, but it took a little bit to start showing signs and symptoms. It could be subacute. You watch that patient for 24 hours. They seemed okay. And then they go home, and about 2 to 14 days later, that bleed enlarges, and then you start seeing all those signs and symptoms of high ICP. So this is your patient that comes into their physician a week later and says, I was in that car accident, and I felt fine, and they kept me in the hospital, but I've had this headache that I can't get rid of, or my vision's a little blurred, or I just don't feel right. That should be red flags, like, That's why you hear of these people that just drop dead from a bleed. Now this is different, a little different. Chronic is weeks to months that bleed develops. That's a slow bleed. But these aren't typically because of an injury. They're more likely your older adults or alcoholics. Basically, their brain becomes atrophied, and there's more space for blood to kind of pool. Does that make sense? As you get older, your brain kind of shrinks in general. And alcoholics, their brain kind of shrinks. So because their brain is shrinking and coming down, there's more space for this blood to occur. and they start getting signs and symptoms. They're often misdiagnosed. They think because it's alcoholics or because they're old, they'll say that they're having like a TIA or a stroke or dementia, right? Because they'll complain their cognitive function will be different, and people will often blame them on that age, or they're an alcoholic, so of course they're acting belligerent, where those are signs and symptoms of high ICP. So they'll have clinical manifestations of confusion, lethargy, memory loss. Does that sound like your grandma? Yeah. That's why they're often misdiagnosed. That sounds like me. All right. An intracerebral is just bleeding within the brain tissue. Typically, it's the frontal lobes. Oops, I'm sorry. Don't freak out. The size of the bleed depends on, like, the patient outcome is dependent on the size of the bleed. Yes. No, they would treat it. They would evacuate it. I'm sorry. Yeah, there would be treatment, but it's not like a medical emergency like the epidural. You're still going to evacuate it. You're still going to get sometimes, I take that back. Sometimes the blood will be reabsorbed. If it's not like, because venous bleeds can be slow, and if you can stop what's causing the injury, or if it's stable and doesn't continue to bleed, then they can watch it, the blood will be absorbed, and they'll be okay. These are like the kids that we see that come to All Kids that get hit real hard. They have a subdural, they have an initial bleed, and then we watch them for a week, and then it slowly goes away. The reason we keep them and watch them for so long is because it has the potential of getting worse, and then we would have to evacuate or do a craniotomy or something to get that blood out. But subdurals, sometimes we can watch because they're slow, and if they kind of clot themselves off and stop, they'll get reabsorbed. But epidurals are not the fact. They're typically arterial, much faster, and they're not going to get reabsorbed. We have to evacuate right away. Good question. All right. So these are your diagnostic studies. CT is the best. GCS, always important to determine the LOC. How are we going to emergency treatment? ABCs, what are we going to do first? Airway. Less than 8. Intubate. Thank you for participating. Y'all should be awake now. I know this is stimulating stuff, but I try to make it less boring. C-spine, right? Because we're talking about, like, let's think of a coupe contra coupe. What do we just talk about with mobility? We want to prevent further damage, right? Prevent further loss of function. O2. IV access, but we want to be careful with our fluids, right? What fluid do we want to be careful with if we're giving too much of it? Hypo, right? Because what's going to happen? Yeah, we can we cause more cerebral edema, especially if we have a head injury patient. See how this is all tying together? Woo! Control external bleeding. We want to minimize blood loss. Maintain warmth. O2. Monitor vital signs. Physical exam. Physical environment. And as always, we want to prevent any secondary injury. Your patient got hurt. There's not much we can do about that initial injury. But if we are on our toes and we recognize early signs and symptoms, if we know we don't have a good blood pressure that's going to maintain CPP, if we're seeing, subtle signs and symptoms of high ICP, if we're catching those things quickly, we're going to get a good diagnosis. We're going to prevent any secondary injury. And we need to get them to surgery if necessary, as soon as possible. Here's some more nursing diagnosis for you guys. Ineffective tissue perfusion because of the hemorrhage, because of the edema. They get hyperthermia because of infection, because of high metabolism. They can't move because they don't have great LOC. So, what do you think our overall goal? We want the brain to get what? Oxygen, right? We want it to not die. Yep, we want it to not die. You're right. That would be bad. We want it to have oxygen. We want it to have perfusion. Because if it's getting its perfusion, if it's getting its oxygen, then we're not going to have the symptoms of high ICP. We want them to be normothermic. We want to control any pain or discomfort. Free from infection, nutrition, and maintain all the function, right? All the things we've been talking about. All the reasons why we're going to catch it and intervene. Maximal cognitive, motor, and sensory function. We want them to function at the highest level they can, right? All right. So in the acute stages, again, all the things that we've talked about, this should all be review. We're going to maintain perfusion, right? Prevent the ischemia. We're going to monitor any changes. The little triangle is a change. Monitor changes in the neurostatus. Patient and family teaching is going to be important, especially if you have that head injury that's bad. You're going to make sure you tell them, because if you watched them for 24 hours and they go home, are you still going to tell them, hey, if they start having any behavior changes, if you notice anything different, we want to see them back right away, right? That's going to be super important that they understand that. Or the patient's really bad off. They're in the ICU. They have a ventriculostomy. They're monitoring ICP. The family's scared. Explaining to them what's going on, what the drains do, what's happening. Eye care, that's a big thing that people forget. The whole point that we blink is we provide lubrication for our eyes, right? So if these patients aren't blinking, they're not getting their eyes lubricated. It's often overlooked, and it's really sad. It really takes 2 seconds to open the eye and put drops in there. Does anyone wake up with dry eyes? I have dry eyes. And I have to, and even after I got LASIK, I still that's why I got it, was because my eyes were so dry. I had a hard time wearing contacts. So I got LASIK, and they said it might be a complication, and I might never get over that. I have to put drops in my eyes every morning because I can barely open them up. It's a horrible feeling. I couldn't imagine going 3 days without that. Maintain normal temperature, prevent shivering. What's shivering going to do? Increase what? It's going to increase those metabolic needs, right? Increased metabolic needs are going to increase the ICP. If leaking CSF, so let's say they had that basilar skull fracture, you tested it, you got a positive halo sign, the head of the bed's going to go up, but you're going to be careful about not going too up, right? About 30 degrees. You're not going to want them to sneeze or blow. You're not going to put an NG, right? No. Any skull fractures, no NGs, because where could that NG end up? In their brain. You don't want anything that's going to increase any pressure because that's going to increase more CSF leaking. So even coughing, anything, you have to be careful. Make sure that you have measures for immobilized patients, bowel, bladder, skin. Even though we want to be careful with turning them, you know, we don't want to be like jacking their leg up and causing a bunch of hip flexion and just, you know, whopping them back and forth. They still need to be moved. They still need to be cared for. Again, that's probably going to be more important to them and their family members than everything that you're doing. So in your mind, you're thinking, I'm too busy right now. I've got to monitor this ICP, and I'm throwing mannitol at this patient, and they're crashing. But all that family member is seeing is that their family is sitting in soiled linens. And that's a dignity thing for them. So although it may not be high on our priority list, we're trying to keep them alive. Make sure that you're getting help or that you're getting involved and that you're reassuring the family that that's being taken care of. Plus, when they get better, we don't want them to have a big decubitus ulcer that now they're going to die from sepsis, even though we just cured them from their head injury. Antiemetics, pain meds. Long term, they may have some motor or sensory deficits. They may have problems with communication, memory. They may not have the same intellectual functioning. I took care of this kid. It was a sad case. He was super smart, straight A's, awesome football player, had a bad hit at a football game, got a bad concussion, grades dropped to like D's, F's. He lost, like his affect changed. He lost all interest in school. He didn't play football anymore. He's doing better now, but it took him 2 years to get back to that, like, just to kind of baseline. He had to end up graduating, getting his GED. So it can have a big, even just something as simple as a concussion can have a big impact on the family long term. Nutritional status, they may have changes in, they may have dysphagia, bowel bladder management, depending on how bad. Seizure monitoring, again, this is all long term with significant progressive recovery, family participation. I'm just going kind of fast because we've talked about a lot of this. Any questions on that stuff? Pretty good? Okay. All right, moving into the home stretch. Brain tumors. Oh. So primary brain tumors originate from the brain tissue themselves. Secondary is a tumor from a primary lesion. It metastasizes. All are deadly if they're not treated. Because the increased ICP, right? So you have this tumor, this space-occupying lesion that's taking up a place where the brain should be. The brain has nowhere to go. You have this closed space, right? So the brain's going to herniate. More than half of the tumors are malignant, and rarely do they metastasize. So if it's like a primary brain tumor that originates, it's rarely going to metastasize somewhere else. So brain tumors vary big time, depending on the location, the tumor size, and the rate of growth. So frontal, people think of what when they think of a frontal tumor? What are they going to have sea changes in? Personality, right? So that's going to be different than if you had a tumor in the occipital lobe. They might have problems with reading or temporal. They might have problems with short-term memory. So the clinical manifestations vary big time. It just depends on where that tumor is, what part of the brain it's kind of taking over. But again, we treat them because malignant or not, they are space occupying. They are taking up space where the brain should be, and the brain will eventually herniate. The size is obviously going to affect. If it's huge, it's going to affect more than one. Rate of growth, they may go from normal to very sick very fast if the tumor's fast growing. All right, so the types, there's gliomas and the glioblastoma multiforme. This is the most common. It is highly malignant, very invasive. It's a doozy. You can also have an astrocytoma. Those are both gliomas. The other type is meningiomas. So what do you think the most common clinical manifestation is? Headache, right? Yep. You guys got it. Typically, it's worse at night. Why do you think it's worse at night? They're lying down. Yep. Lying down increases the pressure. Typically, they complain of dull, constant, or throbbing pain. They can manifest, though, with seizures, vomiting. Again, there's typically no nausea associated with that. If it's a frontal tumor, they could have loss of their emotional center, their behavior changes. They can have confusion or disorientation. Again, memory loss, if it's temporal, depression. And we typically diagnose it by MRI or PET scan. If they complain of a headache and they think it warrants a scan, most of the time what we do, like if it's during the day, we can get what's called a fast MRI. The reason we use MRI over CT is typically there's less radiation exposure because we have to be careful. We used to like, if anyone complained of a headache, we would scan their head. And what we were finding is, or anyone that had a head injury, we would just, yep, go send them to CT, go send them to CT, go send them to CT. And what we were finding is that we were CTing everyone that walked in the door. Our, like, rate of positives was ridiculously low. And then we were exposing all these people to radiation, which was then exposing them to cancer. So we were basically, right? So... Yeah, so again, we're trying to make our patients not die, do the least amount of harm possible, right? So that's why we know, like, that's why we don't say always in medicine or whatever, but we know statistics. Like, we know that for 95% of the time, an ear infection is caused by this organism. So we treat with an antibiotic for that. We know that most of the time, if a patient comes in with these symptoms, it's going to be this diagnosis, so we get it. So an MRI is going to show us if there's a tumor, where the tumor, and how involved it is. A PET scan typically shows us that there's other, like if it's, is this a secondary, so that it came from a different lesion, or is this the primary lesion, and how involved it is, the cancer is. Because that's also going to determine chemotherapy, radiation, all that. All right. So treatment goals, obviously we want to identify the tumor and the location because we want to get it out, right? We need to remove it or decrease the tumor mass. Because if we don't get rid of it, it's taking up brain tissue space. And we want to prevent and manage any high ICP. Surgical is the preferred treatment. Typically, we radiate. We talked about all this just now. Follow up to surgery. And a lot of times, because we can't always remove the entire mass, especially if it's primary, right? It arises from brain tissue, and we don't want to cause too much damage. A lot of times we use medications in conjunction, like steroids, right? Because again, the whole point is we're trying to decrease that tumor so it doesn't take up space in the brain that's going to cause high ICP. So what's the steroid we could use? Dexamethasone, Decadron, any of those. So we decrease the tumor. Anticonvulsants for seizures. So not only are we using meds to help decrease the tumor, we're using meds for the clinical manifestations from the tumor itself. And then we use drugs like chemotherapy. Again, that's to help treat the tumor, decrease the tumor size, to decrease signs and symptoms of ICP. All right. Any questions?